Thank you so much for having me today. And sorry I wasn't able to join you this morning, but I let, the Total Health Conferencing team is amazing. And when they asked me to help moderate, I said, logistically, it's going to be tough, but it's hard to say no to these wonderful women. So I'm sorry I missed you this morning, but I'm excited to be here with you for the rest of the afternoon. So the first talk, I'm going to talk a little bit about circulating tumor DNA in colorectal cancer mainly. And the title of my talk is ctDNA and MRD, the who, the what, and the then what. Here are my disclosures. So I actually changed this a little bit. So this was the title that I was given, the who, the what, and the then what. But actually, it's the what, the who, and then the what. So first I wanted to give you a little bit of an overview of what circulating tumor DNA and cell-free DNA is. So these nomenclatures and the vocabulary around this is quite confusing. So in general, you may hear the term liquid biopsies a lot. But currently, a lot of the work in liquid biopsies in the colorectal cancer space or in just the overall oncology space is really talking about circulating tumor DNA. So there's exosomes, there's circulating tumor cells. So the cells are whole cells. That's different than the DNA. And ctDNA is distinct from cell-free DNA. So cell-free DNA is basically from any source. All of us sitting here today are turning around our cells constantly. And in that turnaround, even your normal cells are releasing circulating cell-free DNA. But ctDNA is the tumor-derived component of that cell-free DNA. And circulating tumor DNA, we can actually get a whole range of alterations in the blood. So we can pick up point mutations, copy number alterations, rearrangements, methylation changes. So a really nice technology now that we're really starting to harness the power of to learn a lot from cell-free DNA and circulating tumor DNA in oncology. So some of the other characteristics of circulating tumor DNA that enables us to use this as a technology that is distinct from, again, cell-free DNA is the base size. So circulating tumor DNA, they have a shorter base pair size than normal DNA fragments. In terms of how they're actually broken down, you just have nucleases that are breaking down these base pairs. And the circulating tumor DNA and cell-free DNA are actually cleared by the kidney. So really, really short half-life and cleared by the kind of renal system. And so some of these characteristics of the base pair size, but also the fragmentation patterns, how tumor DNA fragments differently than normal DNA, as well as methylation patterns, make ctDNA a unique asset in the oncology clinic. So we're going to be talking a little bit about kind of the journey of a patient, and today we're really focusing here on the middle. So these blood-based technologies are coming or in clinic, and they're in clinic currently sort of on the right-hand side, so the metastatic setting, where we're using them now as a complement to tumor-based testing. And I'm emphasizing complement. I don't think that yet these technologies are able to replace tumor testing, and I think we can save that talk for another day of what the limitations are with the blood. And then early detection. So we're seeing a lot more data coming. Some data just presented at ASMA with the Gallery test, which is a commercially available test now, $1,000. And again, topic for another discussion around the early detection space. But what I'm going to talk about today is the MRD space. And I'll give you a definition here of MRD, but this is really the concept of trying to detect residual micrometastatic disease after curative intent surgeries. So here's a definition of MRD I like. So again, the description of persistent micrometastatic disease after definitive therapy. So resection of a primary or after completion of adjuvant systemic therapy. And the idea with MRD is basically you can detect an occult state of disease that conventional imaging may not detect. So when I'm trying to talk about what this is with my patients, I basically tell them you basically need 1 billion cells before you can actually see anything on a CAT scan. So we're really moving the needle in terms of the limits of detection of trying to detect if there is any tumor DNA in the blood. And also for some nomenclature setting and to kind of understand some of these numbers you may hear when you're thinking about circulating tumor DNA, you'll hear numbers around sensitivity and specificity. And What these numbers are referring to, particularly the sensitivity, is basically, say you have 1,000 variant allele fractions, so 1,000 or 100% variant allele fractions. So 100% variant allele fractions, if you conceptualize it, that's 10,000 plasma equivalents in 10 mils of plasma. And when you're talking about 1% VAF or 0.01% VAF, so 1% VAF is, if you had 100% is 10,000, 1% is 100. So you're basically able to detect 100 tumor genomic equivalents. 0.1 VAF is detecting just one tumor genomic equivalent in the background of all this stuff. So you can see some of the challenges. There is some stoichiometric limitation of what you happen to catch in a blood tube at any given time. And I think the other thing to just sort of think about when you're looking at sensitivity and specificity is what actually are these numbers referring to when you're talking about the patients and the performance characteristics of these tests. So this is a reminder, kind of medical school biostats, college 101, that I have to remind myself of often. So sensitivity of these tests is the ability to correctly identify the patients that have residual disease. The specificity of the test is correctly identifying patients without the disease. So here again, your sensitivity is your true positives over your true positives plus your false negatives. And just pay attention to the sensitivity of these tests because the sensitivity currently is what I think sometimes when you get marketing materials and things too, you have to be really careful about which numbers they're reporting when you want to start to think about how you actually want to use these in the clinic. So sensitivity is not just assay dependent, so there are certain characteristics of different assays that enable different assays to be more sensitive. But as I mentioned, part of this is a little bit of how much blood you're just picking, or how many tumor DNA fragments you're just picking up at any given time. So one option is you draw more blood. And so there are some approaches we're saying, let's just draw more blood and see if we can optimize our chance of finding that tumor-derived ctDNA. The other thing that we're seeing is look at more options or more targets. So the addition of methylation, for example, or fragmentation patterns, as well as looking over time. So if you follow patients over time, your sensitivity is going to improve, right? If you're getting a ctDNA test right before a patient has overt metastatic disease on a CAT scan a year later, you may not be able to detect it immediately post-op. And you'll see a lot of these tests are reporting their serial sensitivities as their performance characteristics of the test. And I'm not sure that's entirely fair when you're thinking about the sensitivities. So there's two commercially available tests right now in colorectal cancer. And just as a high-level overview of these tests, there's two approaches. So there's a tumor-informed approach and a tumor-uninformed approach. So the tumor-informed approach is an approach where you take the tumor, you do sequencing, and the particular tumor-informed approach that's available, they do whole exome sequencing, and they picked 16 alterations specific to that tumor, and then they design a probe for that particular patient. And they use that probe over time to follow patients. The tumor-uninformed approach is sort of a fixed-based panel for colorectal cancer that takes the sort of hotspot alterations and adds a methylation signature. And with this, it spares you the need to actually sequence the tumor. And the other advantage of the tumor-agnostic approach is because you're not requiring the kind of tissue to get sent from your pathologist to the kind of company. The turnaround time is a lot faster. But again, there are some kind of pros and cons with it, each approach. The tumor-informed approach, you have the ability to actually filter out things like CHIP and germline because you actually have kind of tumor normal to compare it to. And with the tumor-uninformed approaches, currently you don't. There's some approaches now that are actually trying to take the white cells and do the white cell sequencing in parallel with the tumor testing in order to try to, again, filter out what is germline and what is CHIP. So CHIP is clonal hematopoiesis of indeterminate potential, and it's sort of as your bone marrow ages over time, you see more and more common CHIP mutations, and the problem is some of these CHIP mutations that you see in the blood are actually mutations that you can see in cancers. So P53 alterations, KRAS alterations, so CHIP does become a problem with some of these approaches. So this is, again, just a summary slide, again, of some of the different approaches. The other kind of applications of a tumor-naive approach versus the tumor-informed approach is the ability with the naive approach, you're actually able to pick up new alterations and understand resistance over time. Whereas the informed approach, if you're looking at the same fixed panel, you may not necessarily be able to understand new alterations that are evolving over time. So I want to give you a case. So this was sort of a kind of a patient. Some of the classifiers are changed a little bit for kind of PHI, but a pretty recent case I saw. So this was a 29-year-old male musician. It was a great music school here in Boston. And also highlighting the age, just a plug, 45 is the new 50 for colorectal cancer screening. We're seeing a lot of younger patients with colorectal cancer patients. So this is a patient that's very common now in our clinic, unfortunately. So musician, and I'm highlighting musician because finger dexterity and touch and tactile sensation is important when you're thinking about chemotherapy. And he didn't have any family history, and he presented with rectal bleeding. Many of these patients get presented with rectal bleeding and diagnosed with hemorrhoids long before they see us. And he was found to have a stage 2 colorectal cancer. And when you look at the stage 2 colorectal cancer, some of the features that we look at to try to determine who should not get chemotherapy, he actually really doesn't have any high-risk features that would say that this is a patient that needs chemotherapy. So low-risk stage 2 patient. So what do? So a low-risk stage 2 patient, we know conventionally we would say probably no chemotherapy. But got a test, and this ctDNA test was positive. And I'll show you some data of what that positivity actually means. So going back to MRD, and the problem is for colorectal cancer, the curative intent approach is surgery. So stage 3 patients, all of our patients get surgery, all of our patients get adjuvant chemotherapy, but 50% of those patients are cured with surgery alone. So there's 50% of patients who didn't need that adjuvant chemotherapy that we're giving to them. In stage 2 disease, the standard of care is no chemotherapy, but 10 to 15% of these patients will ultimately recur. So can we have tools such as circulating tumor DNA to really try to figure out who those high-risk patients are that are recurrent, who are at risk for recurrence, and really help us figure out early who may be cured and who may be not cured. Currently, we just don't have, until this technology came around, we didn't have a great way for that. So ctDNA is not necessarily new, but still relatively nascent, kind of in the kind of cancer history. But this was a seminal paper now 5 years ago, or over 5 years ago now, by the Australian group, which has really led a lot of the ctDNA work in colorectal cancer. And what I want you to just see and look at is the Kaplan-Meyer curves. So if you see postoperative ctDNA on the right, you can see that Kaplan-Meyer curve is going down to the axis. Basically what that's saying is every patient who had a ctDNA positive test recurred. So, and the hazard ratio is 18. And you'll see these curves over and over and over again when you look at ctDNA, which I think now there's no question that it really has established itself as the most powerful prognostic biomarker we have. The predictive question is still an outstanding question. And when you look at conventional clinical risk factors in CEA, things we try to use to figure out who is high risk and low risk, you can see that CEA didn't meet statistical significance, and clinical risk factors did, but the hazard ratio was 3 compared to a hazard ratio of 18. And so what they did here is they said, okay, so let's take out risk factors, so let's look in the high-risk patients and the low-risk patients, and they still showed the same thing where, even the low-risk patients that were clinical low risk, if you were ctDNA positive, you were going to recur. So just a couple of other pivotal studies in this space. So this was one of the larger studies that looked at the tumor-informed approach, so one of the commercially available tests. They took patients with stage 1 to 3 colorectal cancer, and they followed them over time. And what you can see, and my take-home message from this slide is look at the single post-op sensitivity. So what you'll see kind of in the lay press as these tests are being marketed is a serial sensitivity reporting of 88% or 90%, even from some other data that I'll show you later. So again, serial testing is following patients over time, and not necessarily, we don't have any data yet to show that early intervention a year later actually matters, right? In colorectal cancer, we have a narrow window, 12 weeks or so, to start adjuvant chemotherapy. So currently, if you just do one time point single testing, your sensitivity is only 41%. So if you have a negative test, are you really feeling comfortable with a single time point sensitivity of 41%, saying that patient should not get chemotherapy? So in stage 3 colorectal cancer, I'll show you kind of other data with sensitivity that's similar. I don't think this is at all useful as a tool to de-escalate care. I think in the low-risk stage 2 population where you have a positive test, you do have equipoise to escalate care. But I worry about the kind of sensitivity of the test currently, particularly in the de-escalation space. So then there's the tumor uninformed approach, and the previous approach was the Signatera test, and this is the Guardant Reveal test. And this is, again, the approach of taking genomic calls and epigenomic calls. And so our group did a study looking at this test, and we followed, again, we followed all stage patients. So we had only one kind of stage 1 patient, a few stage 4 patients, so it was predominantly stage 2 and 3 patients, but patients that, again, were undergoing curative intent surgery. And we compared it to CEA at a single time point, and we also followed patients, a smaller group of patients longitudinally. And what you see, again, so same Kaplan-Meyer curves, everyone who's positive is going to recur with a hazard ratio of 11, and the sensitivity, again, at a single time point is only 55.6%. Reassuringly, at least the positive predictive value at a year follow-up was 100%, the specificity was 100%, but the sensitivity, again, if you just follow patients at one time point, is only 55%. When we followed people over time, you can see that the sensitivity improved. So the kind of some of the numbers you'll see with this test that's being kind of out there is at 90% sensitivity. So that 90% sensitivity is the serial testing sensitivity. It's not really regarding the landmark sensitivity. CEA actually did not, surprisingly, did not predict recurrence. We looked at the addition of the epigenomic calls to see how did the epigenomic calls actually add value. And when you look at the fixed genomic and epigenomic only, you can see that the sensitivity across the different time points improved when you combine the calls with genomic and epigenomic calls. So this is just a figure just to highlight, again, the prognostic value. And I think the prognostic value, again, like I said, has been established. So kind of look at these hazard ratios from all these different data sets. And I think no one else in the community colorectal cancer kind of world is really doubting the prognostic utility anymore. But again, when you look at the sensitivities, and we're not going to go into all of these papers, but the sensitivities, generally are hovering in that 40 to 50% range. Some of the lower numbers, the 70s and 60s, those are actually patients that were kind of stage 4 patients who went like liver resection and curative intent surgery, so a little bit more biased in terms of the stage of those patients where perhaps your sensitivity would likely increase with stage. So then the now what? So we talked about what was these tests, and now we want to talk about what do you do with these tests. And so that's the question that we're really starting to grapple with. Does using this actually help you predict response to chemotherapy, and can chemotherapy actually, for what we call, clear circulating tumor DNA? And what we're starting to see is that yes, so in each of these kind of papers, there's a portion of patients that are clearing their ctDNA. From some of the largest data that we saw last year at ASCO GI from the Japanese group, 68% of patients post-operatively cleared their ctDNA with chemotherapy. And you can see that the clearance matters. So if you look here at the top, the yellow were patients that, or the green were patients that were positive that ultimately turned negative, and they did just as well as the negative patients. So if you cleared initial test, you did very, very well. And if you don't convert to negative, or you remain positive, you don't do well. What's interesting, though, is if you look at, so I talked to you about that 68% of patients that are clearing. What's interesting is that black line. So there's 10% of patients that actually just cleared themselves. Is that some sort of immunologic clearance that's just sort of happening? So we're starting to see this as well, is that, perhaps there is just some clearance that is happening, and whether that's a, limit of the sensitivity of the test versus actually immunologic sort of surveillance that is happening is sort of yet to be determined. But we used to think clearance was 0, but we're learning that perhaps it's not necessarily 0. So I'm just about out of time, and I don't want to kind of get us behind, but I'm just going to wrap up here with an important study that was presented at ASCO and kind of subsequent New England Journal presentation. This was a stage 2 study out of the Australian group, and they looked at ctDNA guided management in stage 2 colorectal cancer patients. The primary endpoint was recurrence-free survival, and it was a non-inferiority design study. So use of ctDNA actually did meet non-inferiority. And what we saw is that there was a 50% reduction of use of chemotherapy with using this test. But what I want to show you here, and again, this is some of the caution we have with using these tests, is so if you look at the ctDNA negative patients, so the yellow patients, so ctDNA negative but have clinical high-risk features, and ctDNA negative patients that have a high T stage, or T4 patients, you can see they do just as poorly in this study as the positive patients. So again, just highlighting the fact that we shouldn't necessarily be using this to de-escalate care yet, because again, some of these patients did have those clinical high-risk features and they did not do as well. So the interesting thing with this study is who are the people actually getting adjuvant chemotherapy? Are we over-treating even some of the lower risk stage 2 patients? But at least the first time we've seen this. So with that, I just want to highlight, I think, put people on clinical trials. There's many now. I think we don't quite yet know how to use these to actually guide patient management. So this is a stage 2 study. This is a stage 3 study that we're leading. And then kind of for reference, I just wanted to put in the deck, the abundance of studies across the globe that are happening in this space. So I think in the next 5 years or so, we'll really start to understand how to use these. So what did I do with this patient? I treated him with FOLFOX, and he cleared and continues to do well. The last sort of thing, I think, again, it's interesting how diagnostics get covered. These are Medicare-approved tests, so these are now, and most commercial payers are paying for them. So we're seeing this in the clinic, and you can sort of see the studies supporting reimbursement, and you can debate today whether or not you think that these warrant reimbursement or not. So with that, I will wrap up. Certainly not a one-size-fits-all, and here are my acknowledgements. So I can take some questions.
So is everybody getting ctDNA testing from you?
Is what?
Is everybody getting tested in your practice? What are you
doing?
So
it's shared decision making. So I, of course, will not withhold a test from anyone who wants it, but I think that people really need to understand that what are you going to do with it, right? And some people feel empowered to know that they have a kind of positive test, but others, that's crippling anxiety. You're just kind of waiting for the next ball to drop. So the only place I'm using it routinely is the low-risk stage 2 patients. Sometimes we get the random stage 1 patients in oncology clinic. Most of the time, they're just done with surgery. And the Japanese Japanese data set, there was actually some stage 1s that were positive too. So it's interesting, should we be even looking at the stage 1s? Yeah, if you're going to do, because I think if you're the only place where you might, if you have an older, frail stage 3 patient, again, the sensitivity is not great, but if it's positive, again, you're okay, then I need to figure out a way to get at least some 5FU in. If it's negative, it doesn't really change that, but at least it maybe convinces me or the family to maybe try to figure out how to do it. Dr. Saeed's a GI oncologist too. I don't know if she has any other additional thoughts on how she's using it in clinic.
No, I think the same. So there's just that hassle that, with what do you do if it's positive? And we're still waiting for those studies to address that, the prospective studies. But I typically get it in the very early stage patients, stage 1, 2 with high risk. But I avoid doing it in stage 3 and obviously stage 4. We're waiting on. I have some studies with immunotherapy, and so I do the Signatera immunotherapy assay, but it's testing, kind of.
Yeah. So I mean, the anecdote of a stage 4 patient where I did use it on was an MSI oligomet patient who had micrometastatic disease, had FOLFOX. We know MSI patients don't do well with chemotherapy, and I would have loved to do this on study, but had a MRD positive test after, and I did give him immunotherapy, and he cleared. So, but that's not very common, but again, another very unique situation in how I used it clinically.
Thank you for the great talk. In breast cancer, we're starting to see it. It's nowhere near as advanced as it is in GI cancers. What has been your experience with coverage and financial cost of the test?
Yeah, so in the metastatic setting, no issue with for profiling at all. In the MRD setting, currently there is a very generous kind of financial assistance programs from both companies, and so if insurance won't cover it, patients will understand what their out-of-pocket cost is, and so far those pockets have been quite deep, so I don't know how long that will last, but for now, not everyone is covering it, but patients haven't been kind of hit with the significant cost yet.
Thank you. So for those stage 2 patients who you decide to escalate therapy, are you still inclined to give them 12 cycles of FOLFOX? Are you ever tempted to give them less?
Yeah, so my approach, and this is kind of not a discussion obviously about 3 versus 6 months even for stage 3 patients, and I can tell you kind of my thoughts on even that, and that might inform this question. So the 3 versus 6-2 was a non-inferiority study, and when you do a non-inferiority study, you're accepting a certain loss of efficacy too. It's a small loss of efficacy, but I see a lot of young patients, and I'm not entirely excited about taking that long, small loss of efficacy. So my general approach, and I think we know that U.S. patients may not tolerate Capox as well either, and we've seen a lot more data about early treatment discontinuation of oxali is probably okay. So actually what I do is I set out for 6 months of FOLFOX, and then what ends up kind of invariably happening is you end up dropping the oxali, kind of 6 to 8 cycles in, and being very mindful and attentive to the neuropathy, so not leaving them with that. But I would get kind of scorched on stage for kind of saying that, because I think some institutions, the 3 versus 6, low risk, high risk, don't feel like that non-inferiority really matters, and we're subjecting patients to toxicity. But I think if you're mindful of the toxicity, and we have data that kind of early treatment discontinuation of oxali isn't impacting in outcomes. So in a positive patient, I will set out with 6 and then low threshold to drop the oxali. Of course, if patients don't want the pump and you want to do the CAPE, then I kind of stick with the 3 months of Capox.
One additional question. You mentioned that circulating tumor DNA is actually cleared by the kidneys. And so when you're taking care of patients with CKD or end-stage renal disease, how are you interpreting that in light of that?
It's harder to interpret in terms of the amounts and things too. So I still think the positivity is still the positivity, but it is harder to interpret even in the metastatic setting. All right. Okay, so I have a disclosure for this talk. So I was not supposed to do this talk at all, and I got a kind of a little bit of a frantic message very late last night from my friendly friend saying, can you do this colorectal cancer talk? And I was like, I can't get slides together. So my gracious colleague from MSK who was going to do this talk let me use her slides, but as a full disclaimer, I've looked at this once. I'm a colorectal cancer oncologist, so I think I can handle most of the data, but so bear with me as I kind of stumble through colorectal cancer. And again, CME accreditation, so I want to kind of stick to some formal objectives, but I'm also just happy to have a conversation on how we think about stage 4 colorectal cancer patients. So I'm sorry she couldn't be here today, and also apologize for botching up her slides. So colorectal cancer actually now is the third most common cancer in the United States, still the second leading cause of death. So it's a common cancer, as we talked about, young, tremendous increase in early onset colorectal cancer patients. The newest sort of data suggests that kind of 1 in 10 of colon cancer patients and 1 in 4 of rectal cancer patients will be under 50, so pretty striking numbers in terms of what we're seeing in the clinic. So here's just a kind of a map of the biomarkers, and the biomarkers are evolving quickly. So MSI high is kind of, as we all know, an important biomarker. RAS, and in RAS, until this last year or so, really RAS alterations were a negative predictive biomarker of lack of efficacy to anti-EGFR therapy. But we're seeing some really exciting data in subsets of RAS with new RAS targeting drugs. So the most first kid on the block, which obviously has much stronger lung cancer data than colorectal cancer data, but still compelling data in colorectal cancer, is G12C. And there's other RAS alterations that are coming. So now actually important to pay attention to KRAS G12C. BRAF, V600E, and other BRAF alterations. As of a couple years ago, we actually have effective BRAF targeting therapies. Again, the effect you'll see is still quite dismal in terms of what we would like it to be, and lots of opportunities to really improve on that efficacy. HER2 has had a very kind of exciting couple of years now with many HER2-directed alteration approaches. Unlike breast cancer and colon cancer, the HER2 we see is more amplifications rather than point mutations. So we do see some activating mutations in HER2, but quite rare. We see some rare fusions, so some NTRK and others. Most of the fusions actually overlap with MSI high status. And then there's one other one that I would have actually added into here that is not colorectal cancer specific, but we saw some really great data at ASCO, and we do see in a couple of percentage of colorectal cancer patients is the P53 Y220C alteration. We saw some remarkable kind of monotherapy activity with this P53 inhibitor at ASCO, and again, it's a rare subset, but even P53, you need to start paying attention to which P53 alterations there are across tumor types. So that was an all solid tumor study. So I would actually add that in here. So small, but we do see it in colorectal cancer too. So here is our kind of roadmap and our toolbox of drugs that we have. So cytotoxic chemotherapy and so obviously 5FU, oxaliplatin, irinotecan, Lonsurf, a couple of VEGF inhibitors, anti-EGFR inhibitors, BRAF, and MSI. And again, I would have put the TRK inhibitors as well on here. So when you're kind of looking at the landscape of colorectal cancer, what you can see is really the needle was first starting to move with the advent of 5FU chemotherapy. So when you look at the kind of median overall survival sort of in the 80s, which is sort of best supported care, we started to see an upwards of an upward deflection of that median OS with 5FU. And with the addition then of other cytotoxics as well as monoclonal antibodies, we saw an improvement of overall survival. But I think it's still disappointing is that the overall survival in colorectal cancer really hasn't changed beyond this kind of 30 months for the all RAS wild type patients over the coming last few years. So when we think about colorectal cancer, besides the kind of classic biomarkers, I think of sidedness as a biomarker. So we are learning more and more that the side of the colon matters. So if you're right-sided, we knew for actually some time that right-sided cancers do poorly, but what we didn't really understand was how the side of the tumor may impact actually drugs and particularly anti-EGFR therapies. And I'll show you some of that data. But what we now know is that if you actually give first-line anti-EGFR therapy to patients on the right, those patients actually do worse with therapy than left-sided patients. So when you have a medical student working with you, a resident, it's no longer just 42-year-old male with colorectal cancer and biomarker. It's sidedness is part of that kind of tagline, which is really important. We put sort of the biomarkers based on sidedness on here, and this is quite accurate. We tend to see more MSI on the right, more BRAF on the right, more KRAS alterations on the right, and left side, especially rectal cancer, is where we see a lot of HER2. All right, so just a brief kind of historical background of cytotoxic chemotherapy in the first-line setting. So this is where we started from. So we started with FOLFOX, FOLFIRI, FLOX, and what you can see in terms of OS again and response rate sort of hovering in that 30 to 40% range with OSs 16 to 20 months. So we knew we needed to do better. So what did they do to try to do better here? They tried to escalate chemotherapy. So we have 5-FU, we have oxaliplatin, we have irinotecan. Let's all put it together and see if that helps. And we did see with FOLFOXIRI, a few studies now, we did see an improvement of response rates and a trend in a couple of studies. In one study, the TRIBE study, which we actually did see a small survival benefit with triplet chemotherapy. But what you see with triplet chemotherapy is significant toxicity, so neutropenia, diarrhea. We've gotten much more adept at how to give FOLFOXIRI, and FOLFOXIRI is different than FOLFIRINOX, which you use in colorectal cancer or in pancreatic cancer. But kind of the general approach that I take to even this triplet therapy, even if it's called FOLFOXIRI, is a more modified FOLFIRINOX approach. If I'm choosing to use triplet chemotherapy where you don't take the 5-FU bolus, you drop the bolus, you lower the dose of irinotecan, and again, a lower dose of infusional 5-FU in modified FOLFIRINOX than in FOLFOXIRI. And so, okay, now we had all three drugs combined, and we have doublets and triplets, and now we have angiogenesis. And so we know that angiogenesis is really important in colorectal cancer. So what do? So let's add anti-angiogenic drug, bevacizumab, to our chemotherapy and see how we do. And I think this slide is just, what I actually think of looking at these data is look at the difference with kind of Bev, which is one of our kind of key tools that we have for metastatic colorectal cancer in terms of the OS difference. So, only a few months still, and interestingly in the UK, they decided that this few-month difference was not enough to kind of warrant having Bev on formulary. So for patients in the UK, they actually don't have access to bevacizumab in terms of a kind of health system kind of cost versus benefit. But I think we spend a lot of time kind of agonizing around the use or not use of some of these therapies. And again, a 4-month difference is meaningful, but some countries would say perhaps not meaningful enough to kind of cover it as an option for patients. Main thing that we see with Bev is really kind of some proteinuria. There's a lot of scare around the GI perforation risk, but it's actually quite low, as you can see here with a 1.5 difference or 1.5% perf rate here in this study. So we had chemo, we added Bev, and now let's add triplet to Bev. And this was the study that I was mentioning that we actually did see a survival benefit with the triplet versus the doublet, so 25.8 versus 31.0. So we've seen subsequent data that even that couple month OS benefit is not as great, maybe only on the order of 6 weeks. So you have to be really thoughtful about who you're using these for. I tend to use it in our high disease burden patients or as a conversion tool for resectability because response rates are better. You can kind of get 60 to sometimes even 80% response rates with this. So I will, in this study it was 65%, but there's been some other data sets that you can get higher responses. So that's the kind of patient population that I tend to use it in. In this study, there was a trend towards benefit for the BRAF patients as well, and so given their kind of poor prognosis overall, that's another group of patients where I'll think about triplet therapy for. Then there's anti-EGFR therapy. So we know that EGFR is an important pathway in colorectal cancer, and the monoclonal antibodies, which you see here, cetuximab and panitumumab, bind to at the surface level. And what I think is important in the signaling pathway is to look at all the various nodes of resistance that can emerge with exposure to anti-EGFR therapy. So some of the problems with targeted therapies is that you get downstream resistance in each of these nodes, and that nodes, all those resistant alterations in those nodes ultimately cause patients to become kind of resistant to these therapies. So there is cetuximab was kind of the first kid on the block, and the first study was looking at patients that had progressed while on or within 3 months of irinotecan, and looked at the addition of just irinotecan to cetuximab. And what you can see is cetuximab alone versus cetuximab with irinotecan, better response rates, and a statistically significant difference in survival with the addition of irinotecan to the cetuximab. Sort of same thing with PMAB, and I only have a few seconds, and her deck is quite long, but I think the kind of key point here is this. I wonder if I can go back. Is this. So this was the study that really kind of laid the land for why anti-EGFR therapy was not to be used in patients that were KRAS mutants. So you can see best supportive care versus cetuximab, the response rates in OS for the RAS mutant patient populations. And if you look at cetuximab monotherapy versus best supportive care in the wild type patients, that's where you actually see kind of some benefit. So I think what I'm going to do is I'm just going to kind of skip chemo and just want to highlight a couple of the targeted therapies that are now available. So this was BRAF targeted therapy, and for V600E, which now has an FDA label for refractory patients to chemotherapy. They're looking at this approach in the first line. Some safety results were just presented from the Breakwater study at ESMO a few weeks ago. But what we saw in the Beacon study was a response rate of 48% of patients with the combination of initially the 3 drugs. But what ultimately got into the label is, and I'm going to go to the updated, this was the initial NEGM paper data, but this was the updated results. So what ultimately got into the label was the doublet, so encorafenib and cetuximab without the MEK inhibitor, the binimetinib. And that's because there was no difference in overall survival, but a much higher kind of toxicity profile with the 3 drugs. And having treated patients with 3 drugs, it's tough. But you did see a slightly overall response rate, but in the metastatic setting, the kind of FDA-approved NCCN guideline approach is now doublet versus the triplet. So again, HER2 more on the left side there. A couple of options prior to actually ESMO GI this year, where we saw the Mountaineer data. Small studies, but because of response rates, kind of 30% with lapatinib and trastuzumab and pertuzumab, these got into the NCCN guidelines. One important thing to know with HER2 is that KRAS alterations are a negative prognostic biomarker and kind of portend resistance to HER2 therapies. And same thing with anti-EGFR therapies. If you have a HER2 amplification, there's pretty compelling data that the use of anti-EGFR therapy in even a RAS wild type patient with the HER2, that may be a resistance mechanism to anti-EGFR therapy. Will I use it in the later line? Yes, because there are a small subset of patients that may benefit, but the kind of dogma is that HER2 is a resistance mechanism for anti-EGFR therapy. So what is getting kind of now sort of at the FDA, which hopefully we'll see approval soon and should be in the guidelines in the next few months, is tucatinib plus Herceptin. And this was the Mountaineer study. And her data from Mountaineer is a little bit an older data set, but what we saw is about a 40% response rate from Mountaineer. and overall survival of upwards of, it was almost 2 years now for HER2. And Herceptin and tucatinib is much better tolerated than Herceptin, lapatinib, and Herceptin and pertuzumab. Then there's trastuzumab deruxtecan, which also has an impressive overall response rate, but the bottom slide here, or the bottom line here, is important. So there is an ILD rate 6 to 10% there, and we're not going to ever have a trastuzumab deruxtecan versus a monoclonal antibody TKI sort of combination. So the way I've been sequencing this, practically speaking, is given the tucatinib and trastuzumab first, and then rebiopsying, confirming that they remain HER2 amplified, because as you can see here, if you were not HER2 amplified, you did not benefit. So if you were IHC2 plus or ish negative, your response rate was 0. So we haven't seen the kind of breast cancer bystander effect yet. And then we'll expose patients to trastuzumab deruxtecan after they've already gotten a double combination. So with that, I'm just going to stop. I think we all know about MSI high CRC quite well. And we'll just go to the poll questions, which it's okay if you get wrong since I didn't get through all the material. So what is the best first-line treatment for a patient with a cecal cancer metastatic to the liver and lungs? So cecal cancer. Okay, poll question 2. Which of the following is the best treatment option for BRAF V600E mutant colorectal cancer after progression on first-line FOLFOX? Okay, so poll answer 1 with the cecal cancer, FOLFOX and VEGF, and I didn't get into the kind of data around cecal cancers and why kind of VEGF may be better than anti-EGFR that much, but that's the right answer. And then encorafenib and cetuximab. All right. So thanks for bearing with me for that.